Good morning. My name is Steve Simoneau, and I'm a pediatric radiologist in Atlanta, Georgia. And today I'll be discussing the early development of the diagnostic radiology remote oral examination. My only disclosure is that I'm an ABR volunteer and currently the pediatric radiology trustee and vice chair for diagnostic radiology. I also took the oral examination and was an examiner myself and helped develop content for the old pediatric oral exam. I have no relevant financial disclosures, and all the information is current as of today. I'd like to start with the ABR mission, which is to certify that our diplomates demonstrate the requisite knowledge, skill, and understanding of their disciplines to the benefit of patients. The numbers below are the total number of diplomates who have been certified in each of the 4 categories, which include diagnostic radiology, interventional radiology, medical physics, and radiation oncology. And as you can see, the vast majority are in diagnostic radiology. I've always been curious about that word diplomates and wondered if it was even a real word. So recently I went to Merriam-Webster.com to look it up, and it turns out that it is. According to Merriam-Webster, a diplomate is a person who holds a diploma, especially a physician qualified to practice in a medical specialty and who has passed an exam like we do in the ABR. The oral board has a long history and has been given since the very beginning of testing. The oral exam used to follow written tests in physics and clinical radiology. Over the years, it has been given in various sites, including Dallas, Cincinnati, and even Miami Beach. But in 1980, the board landed on Louisville, Kentucky as the site to give the examination, and it remained there until the final administration in 2013. So why was the oral board examination replaced in 2013? It was noted at the time that radiologists were becoming increasingly subspecialized. This was true in academics, but also in private practice where people tended to specialize in a certain area. The certifying exam then was thought to need to represent the shifting focus of radiology towards more subspecialization. And there were also concerns about the subjectivity of the oral board format. The cost to candidates who had to fly to Louisville, stay in a hotel, and pay for meals had to be considered as well, and these same costs were borne by the American Board of Radiology. Then there were the logistics of travel to Louisville for everyone, which could be challenging. So why is the ABR bringing it back now? Well, it was increasingly recognized that multiple choice examinations do not mirror practice. Even though the exam currently is mostly image-based, some diagnoses are difficult to test, and differential diagnoses can be hard to explore in a multiple choice format. It's also very difficult to judge people's observational skills and their ability to detect lesions. The ABR also reached out to stakeholders who were noting that the subspecialty focus of the exam limited broad knowledge acquisition. In the old format, people had to study for a multiple category exam, so their preparation was more extensive. And as the years went by, training during residency was mostly focused on this computer-based exam and not future practice. Also, the computer-based format is not an optimal way to evaluate for synthesis of findings, communication of results, and for professionalism. What are the other ABMS boards doing? Currently, 14 of the 24 administer some sort of oral examination for the certifying exam. And even within the ABR, except for diagnostic radiology, all the other disciplines, IR/DR, medical physics, and radiation oncology, all administer an oral examination. Diagnostic radiology is the only ABR discipline with no oral exam. So let me give you a little information about the old oral board examination. First of all, as I've mentioned, it was administered in Louisville, Kentucky. There were 10 sections and 1 virtual category. The 10 sections were MSK, thoracic, GI, GU, neuro, vascular interventional, nuclear medicine, ultrasound, pediatrics, breast, and cardiac. Cardiac was the virtual section, and cases from thoracic, nuclear, and peds were taken in aggregate to score that section. There were 25-minute sessions which contained a 5-minute transition period. At the end of 20 minutes, a chime rang to alert examiners to wrap up the session and to send the candidates on to the next room. Testing occurred over 4 days. There were standardized case sets, but no standard unified scoring matrix. And we had one category meeting at the start of the week and daily panel meetings to discuss the candidates. So what were these examiner meetings? Category meetings gather all the examiners in a category like chest or abdomen to discuss the cases. In the old format, this was more of an orientation. So at the beginning of the week, the PEDS examiners, for example, would gather and go over a rough outline of the week's schedule. In the current oral, there's more opportunity to discuss case performance during the same day panels and to standardize how the cases are scored. Panel meetings are groups of examiners from each category who examine the candidates in the same session each day. These panel meetings meet to determine the final scoring for each candidate in each day's session. How will the new oral certifying examination in 2028 differ from the old format? Well, instead of being given in Louisville, this will be a virtual and remote administration both for the candidates and the examiners. The categories will be narrowed down from 11 to 7, and those will be abdomen, breast, chest, MSK, neuroradiology, nuclear radiology, and pediatric radiology. There will be 25-minute sessions with a longer 10-minute transition to accommodate the more technical aspects of the handoff in the virtual format. To get all candidates tested, it will take approximately 10 days of testing. And in addition to the standardized case sets, the format of the test will be standardized as well to minimize subjectivity. And instead of a single category meeting, there will be daily category meetings with daily panel meetings as well. So let me review the changes that will be made to the oral exam categories. In the old oral, MSK was a single category and will stay the same. On the new exam, thoracic and cardiac will be combined into the chest section. On the new exam, GI, GU, and portions of ultrasound will also be combined to form the abdomen section. Neuro, breast, peds, and nuclear will stay the same. The interventional portion will not be a separate section, but will be divided up amongst the various categories. On the old exam, ultrasound wasn't exclusively being shown during the ultrasound section, but was spread out amongst the various categories, and that will stay the same. We have decided that peds content will be limited to peds, and the nuclear content will be limited to that area. So, for example, you should not see a pediatric brain tumor in the neuroradiology section because that will be included in pediatrics. Just as on the old oral exam, it was impossible to test every concept in radiology, the same will be true on the new oral exam. Cases will be shown in each category that cover important diagnoses. We also intend to evaluate skills that can be difficult to assess on a computer-based examination. And these include observational skills like finding detection, discussion of cases, ranking of the differential diagnoses, next imaging steps and recommendations, and what I like to call heightened awareness cases. So on a computer-based exam in pediatrics, for example, once non-accidental trauma or child abuse is listed as one of the options, the candidates go back and look very closely at things like the ribs and spine to look for fractures. By including this diagnosis as an option, it makes it difficult to test candidates' ability to find this. Physics, non-interpretive skills, and procedures will be tested in the context of cases and not separately. And there will be coordination of the case material across all the categories, something that was not done on the prior. No normal studies will be shown, just as was true on the old oral. So this is a completely hypothetical grid made up to show how case coordination can be accomplished across multiple categories. The only thing on here that's accurate are the categories, abdomen, MSK, and peds. But undoubtedly within each category there will be some sort of subcategory listing. And this is an example of how we can coordinate across the cases. Just to show that, for example, osteomyelitis is being shown twice in this session, which could be appropriate but should be considered. Tumor cases, which are here highlighted in that sort of yellow color, appear across the examination, but maybe in abdomen there are just too many in that one session. Modality mix can also be included to make sure that it's not out of sync and not too many of one modality is being shown. Here we have a slide summarizing some of the differences between the new and old oral examination. The first difference is the location, with the old oral exam being given in Louisville, Kentucky. The new oral exam will be remote both for the examiner and the candidates. There were 11 categories on the old oral exam and 7 on the new. The session length is 25 minutes for both, but a transition time was built into the session time on the old oral exam. A 10-minute transition will be present on the new oral exam for the technical aspects. So overall lengths of testing for both exams will be approximately the same. It'll take longer to do the new oral exam testing because of the limitation on the number of sessions that can be performed each day. So it took 4 days of testing on the prior, but it'll take approximately 10 days of testing for the new. There was 1 category meeting on the old oral exam, and there'll be category meetings each day of testing on the new oral. Standardization on the old was limited to the case set, whereas on the new oral exam, both the case set and the scoring and the format of the exam will be standardized. And also case coordination, which was not being performed on the old, will be performed for the new examination. So what will a single panel look like on the new oral format? Well, there will be 7 candidates in each panel, and a simultaneous start across the continental US. So if you look at this grid, you can see that candidate A starts in peds, goes for 25 minutes, then moves to breast, then chest, then abdomen, MSK, neuro, and nuclear. After those 7 periods, a recovery period is inserted that allows candidates who might have had a technical or connectivity issue an opportunity to retest in that area immediately. After that recovery period, the categories will meet to discuss the cases, and then at the panel meetings, the examiners from each category will meet to discuss each candidate's performance and come up with the finalist scoring. The examination will be administered over approximately a 15-day period. There may be only 10 days of testing, but a break will be needed in the middle for the staff and the examiners. But for a candidate, there's only 1 day of testing. Volunteers will probably need to agree to examine for at least 3 days to be considered. A minimum of 150 examiners is needed per week, and that's if each examiner did all the sessions. Since we don't expect examiners to do all those sessions, more volunteers than that will be needed. So roughly 20 to 30 examiners will be needed for each category. For reference, in Louisville, there were about 400 to 500 examiners. So what about conditional passing? In the old oral examination, there were 11 categories, and you could condition 3 of these categories, which was about 27%. And then when you came back to be retested, you only took examinations in those areas that were conditioned. With the new oral examination and 7 categories, conditions will be allowed in 2, which is about the same percentage as on the old oral examination. What about the timing of the examination? Well, currently the core examination is given during the 3rd year of residency, and the certifying exam is given 15 months after the completion of residency in approximately September. In the future, the core examination will stay the same. It will still be given in the 3rd year of residency, but the certifying examination will move to the first half of the calendar year following the completion of residency. This is the same timing as IR, medical physics, and radiation oncology. As an example, the current class of radiology residents that began in July of 2023 will take the core examination in 2026 and then have the first opportunity to take the certifying exam in early 2028. This is a high-level project plan for the oral examination. In 2023, we defined the panel grid that I showed you earlier, showing the categories and the timing. In 2024, we developed the final written certifying examination, and the RADS program used to construct the examination is being modified for the new oral exam structure. In 2025, we'll reconstitute oral exam committees and finalize the testing format. In 2026, or probably earlier, volunteer recruitment will begin. The blueprint for the examination will be finalized, content development will begin, and the study guides will be developed. In 2027, the examiners will be selected, the exams themselves will be scheduled, and the oral content will be formalized in the grids. In 2028, the examiners will be trained, the examination will be given, and then the process of beginning the oral exam construct will start. I thank you for your attention, and I hope this very brief overview of the work that's being done to develop the oral board has been helpful, and more information will be upcoming in the months and years ahead. Thank you.